we wanted to call out some highlights at some of the recent congresses, specifically at ESMO 2025, recently in Berlin, where we saw some posters on NTRK and NTRK inhibitors. One that stands out to me. There is this poster at the top is real world outcomes. We know what the clinical trials, we just articulated what we saw in trials. I thought this was interesting in that TRK inhibitor use was still low in this real world population of NTRK solid tumors. Now, this wasn't just a lung cancer population, it was all solid tumors. And interestingly, most of the time these were being used in the later lines. Luis, does that surprise you that only 24% of patients getting a TRK inhibitor? In this series?
Unfortunately, I have to say that, for example, in Europe and maybe some other places worldwide is even worse. I mean, we have a big issue with NTRK drugs. For a while, this has really been improving, but even, let's say, France, Italy, Spain, for a while, those drugs were only reimbursed for patients with, for pediatric patients, but not for adult patients. So I think that was part of the issue. Thank goodness this issue has been recently solved a couple of years ago. And I mean, that is the reason I think that number was really low. Of course, you go to South America, many places in Asia, thank goodness, this scenario is very different in the US. You're lucky about that, but that is a big issue. Having a good drug, a good therapy, and not being able to give it to patients, that is really, really tough.
Yeah, I think what you're hitting on is access. Access is critical, and I think you're hitting on important points, which is that even when people see the data, right, then being able to access the drug is the critical piece. Just rounding out some of the other abstracts here, we saw updated data. Another real world study looking at larotrectinib. Here seeing a impressive response rate of 61% in non-CNS tumors, dropping down in CNS tumors. Obviously, we know that while these drugs are CNS penetrant, the biology of those tumors are quite different. I think it's nice to see data that recapitulates what we're seeing in the clinical trials. Likewise, with our colleague Benjamin Bess presented a poster updating the repotrectinib data. And I would say, to me, what's striking in this update was the TKI pre-treated response rate with repotrectinib. So 50% of patients previously treated with the TKI is still having an objective response rate. So I think that's really encouraging, and I think it speaks to, at least showed us some of the data on mechanisms of resistance, and highlighted some of the early data with repotrectinib, and I think this provides some additional data there. And then rounding out the list, we see the larotrectinib long-term responders seeing a 5-year PFS rate of 68%. So a subset of these patients can have really durable responses, but we still need to push things forward and develop next generation inhibitors, because we know that acquired resistance continues to be an issue. So with that, please.
No, I think those data, particularly the long-term data, are really amazing, I would say. And, we typically have as a reference in the targeted therapy world, the data with LORLA in ALK-driven disease, like 60% PFS at 5 years. And the data here are even a bit better. So I think that is very important to keep this message to our patients. That is amazing.
I completely agree. And I think that's a perfect segue to our first question, because someone asked the question of how are TRK inhibitors going to change the prognosis of NTRK fusion positive lung cancer? And I think you just started talking about it. So maybe if you want to expand more.
Yeah, so I think, if you look at the very few patients that we now know in retrospect that they were NTRK positive but treated with chemo, that was a totally different history. So we know now those patients are really living for a very long time. Even, as you mentioned, we know even patients that had been progressing to first line TKIs, they still have a very good chance of responding to next generation drugs. More than half of the patients do respond, and survival is still quite reasonable. Going to nearly 2 years. So I think those data are really encouraging and have to be really transmitted to our patients.
I agree. And I think it also underscores the importance of making sure that we're managing the toxicities well, right? So if someone's going to be on a targeted therapy for 5 years, we really can't have them being dizzy every day, right? These are, things that for a day or so can be disruptive, but then if someone's living with that for years, it really is important for clinicians to ask about it, identify it, and then course correct, because these patients are living longer. Another question came up for you, Lynette. That is, given all the diverse fusion partners, what should clinicians look for in an NGS panel to check, if appropriate? And are all RNA sequencing approaches equal for NTRK detection? So I guess two questions there.
Yeah, they're very good questions. And I think take those one at a time. The diversity of fusion partners probably has the biggest impact on a choice of a DNA sequencing panel. So as I discussed in my section, one of the challenges with NTRK fusion detection from DNA is the fact that the locations of the breakpoints in fusions occur in very large introns, generally speaking in NTRKs 2 and 3 in particular. And it makes it very hard to capture those breakpoints in a DNA-based assay. So you may be chasing them from the partner side. You may have better luck capturing that 5' partner than you do that kind of key kinase domain mechanism on the NTRK side. So you can hope that you build a panel that is able to capture that information off of that 5' partner, and maybe you just happen to sequence into that NTRK 3' component. So that's not the best strategy, honestly. So, alternatively, you just commit a lot of resources to covering those huge introns. That can drive up the test cost, and I think a lot of labs have tended to steer away from that, ultimately leading to a general recommendation that you would pair that DNA-based strategy with an RNA-based test, and that could certainly be a targeted fusion assay, a targeted RNA assay, where you're just looking for fusion transcripts from a given set of known oncogenic drivers. And I think those approaches work very well. The challenges can be if you have a degraded sample where the RNA is not good quality, you may not get a successful test. So there's always some challenges with handling RNA. One thing I would just like to point out is that as excited as I think we all are about things like whole exome sequencing is not going to get you your NTRK fusions, right? It's not a good strategy for detection of fusions. You have to then pair it with another RNA-based strategy, which could be, say, a transcriptome. So you could do RNA transcriptome. My experience is that RNA transcriptome is great for defining kind of a whole transcriptional profile, but sometimes it's not going to be quite sensitive enough to define these individual fusion alterations. So I think we're still getting there with the RNA sort of transcriptome technology for sensitivity of detection. For most places, I think a good quality comprehensive panel paired with a targeted RNA assay that's ensuring you've got coverage over your NTRK genes is probably the best strategy.
Yeah, as someone who's done lots of exome-based projects, it's always funny because commonly you then focus in on the 100 or 200 cancer-related genes, right? So even though you do the exome, you're then focusing on just cancer-related genes. And your point about that not getting you the fusions is a really important one. So, Luis, you showed some of the data on mechanisms of resistance. We have the on-target track mutation, solvent front, gatekeeper, but we also know resistance can emerge through off-target mechanisms. And so I think this individual was asking about how we should go about targeting off-target resistance and bringing up MAP kinase pathway if you were to see acquired KRAS, for example. How might you approach that here?
Yeah, always that is feasible to me. So if the mechanism of resistance is having a clear drug that is effective, such as the case today for G12C inhibitors, I tend to keep the NTRK inhibitor and add on the new inhibitor to the new target. In that case, G12C inhibitor. I mean, ideally, you like to have safety data for that combination. Maybe the first time that is being done. So sometimes you cannot wait to have 30 patients treated and published, and then you have to decide. So I tend to comment my patients after discussing with the multidisciplinary team, and I just be careful the initial weeks and tend to be monitoring very carefully, including blood tests and so on. But, I had just very recently a case with MET amplification, and we are giving the NTRK inhibitor plus TEPO without major issues. So I think for most of the cases it's feasible.
Yeah, and we see, some of these bypass pathways, right, tend to be promiscuous. You mentioned MET, and that comes up over and over and over again, right? We see that in EGFR resistance, we see that ALK, and we can see that here. We have time for one last question, and that is, this speaks to some of the efficacy data, but is how do you counsel patients in terms of like what they might expect in terms of the average time before they might expect to see resistance, and how do you treat oligo progression versus kind of more fulminant progression?
So the way I typically address this is, I'm having them like, I would say more than half of the patients could be okay in 5 years without progression. So that may happen earlier, but, that gives them kind of a time. Second thing is, as you mentioned, if I'm seeing some oligoprogression or very slow progression, I tend to try always that is possible a local therapy and keeping on my NTRK inhibitor. Most of the cases, that means stereotactic radiation, but in some cases, it may include surgery, but more frequently stereotactic radiotherapy. But that, and sometimes you see patients that are having maybe some 2 extra years of disease control by doing so. So are you using that approach as well, or?
Yeah, very, very similar. I think even though NTRK is rare, right? We take the same paradigm that we use for other targeted therapies, and I think extrapolate here. So our approach is very similar, and I also think that your willingness to continue beyond progression or SRS is also depends on the quality of your next line therapies and what other targeted therapies you have. So you might be a bit more willing to switch after if you have an excellent option. So that's why I think it is so important to have all these next generation TRK inhibitors.